Thank you very much. Thank you, Rakesh, for a nice present introduction. I really appreciate. Before I start on diabetic foot infection, when to suspect and how to classify, I would like to take this opportunity to thank organizing committee and especially Dr. Banchi who invited me, and more especially for those people who are working day and night behind the curtains, which we don't see them. Thank you very much, all of you. I come from Dar es Salaam, Tanzania, East Africa, which is a land of Kilimanjaro, Ngorongoro Crater, largest game park, Serengeti, and Zanzibar Stone. We are going to talk on infection, and this is an international working guidelines, the diagnosis and the treatment of foot infection in presence with diabetes, which was published on last year on 24th of May, and we were 12 of members. You can say 12 angry people. These were the people who made the consensus and sat for 4 years, starting from 2015 to 2019, which was led by Benjamin Lipsky. So a systemic review of intervention in the management of infection in diabetic foot was prepared by International Working Group from these 4 years which I mentioned. We identified the total papers out of this 15,300 papers. Every member had to review 1,300 papers. Eligible out of this were 226 papers which were fully reviewed. So it got to 52 fully papers to be reviewed by each member, and we included 53 papers, 48 were from the literature survey, and 5 were added on additional. Coming to a diabetic foot, the natural history of diabetic foot, usually we have a normal diabetes foot with no problems, no risk factors. This follows with a high risk factors and which are very common in our setup, Africa and Asia. And you can see this severe form of autonomic neuropathy, loss of muscles. This is a motor neuropathy with flowing of the toes, and sensory is also present, or peripheral arterial disease where there is a reduced in blood supply. Then once you have a high risk factor, you lead to an ulcerated foot. Ulcerated foot leads to an infected foot, which is very common, and that's how they present to us. And this is the topic today we are going to talk, which is highlighted in yellow, you can see. And the infected foot ends up with necrotic foot. So let's go to diabetic foot infection. As we are all aware that infection is an immediate cause of amputation, 25 to 50% of the patient end up with amputation. It depends where you are in the world. Overall, 40 to 60% of all non-traumatic diabetic amputations are performed in the world. That is 20 every 20 seconds. That means 3 in 1 hour. 85% of amputations are always preceded by diabetic foot ulcers. And once you have an amputation, there is a 50% of risk of having a second limb amputation within 2 years, and 50% of risk of mortality within 5 years. So diabetic foot infection is defined as a soft tissue or a bone infection anywhere below malleoli in a person with diabetes. The burden of diabetic foot cannot be addressed without talking about infection. Foot infections are very common, complex, and very serious, dreadful problem in diabetes patients. Infection can cause prolonged hospital admissions, and the cost is completely unsustainable to the patient's family, relatives, or even the friends, society, and in large to the nation. Diabetic foot ulcers in our continent, that's Asia and Africa, invariably when they present to a doctor, they are already infected. And in typical presentation, first presentation to the doctor, when we see them, they are already involved. So the bone is already involved, grade 3, or there's already a localized gangrene or a full limb gangrene, and it's a limb-threatening infection or even the life-threatening condition. The challenge is to find solution to the problem posed by diabetic foot disease. And I'm very much interested when I sat in this international working group, especially for us in poor resource countries. So infection, as we all know, is a main pathway to necrosis. Host response is always reduced in diabetic patients. We very well know this. So early diagnosis and intervention is very necessary to reduce amputation and death. In our setup, typical sequential timeline of the patient decision, to seek medical help is patient usually start treatment at home, and it's very common putting herbal and all these things, using a razor blade or a herbal bath, visit to herbal fat healers or a traditional healers. Then they visit to the primary health centers, that is a grassroots level where we do not have a specially facilities for diabetic foot, visit to district or regional health centers, and by the time patient finally referred to our place is often too late to save the foot or even prevent the death. So this is called diabetic foot attack. This is an emergency condition, similar to what we see in myocardial infarction or in cerebrovascular accident. These are the four feet which need to be taken very seriously and has to be intervened very fast. And it's an emergency in diabetic foot. These are the feet which comes to us after the history of days, weeks, and years of ulcers, infections, and sometimes misdiagnosed and treatment. And we should not be seeing these feet anymore in 2020, but we still see them in Asia and Africa. So what are the clinical categories of foot infections? Three most important clinical categories: cellulitis, which is the least infection, and this commonly falls under the jurisdiction of physicians, which we are all, but we see more than that. Deep soft tissue infection, which involves the muscles and fascia, or a chronic osteomyelitis, which involves the bone. Cellulitis is the most common foot problem, characterized by erythema, swelling, heat, and lymphangitis may be present. Surgical debridement here it is not required, and it can be treated purely on medical grounds. Soft tissue infections involves the deeper structures. Here, necrotizing fasciitis can be a life-threatening condition, and if it is not urgently debridement is not taken, we can lose the patient. And it has been seen, and you must have seen in your practice, once the debridement starts, you can see the patient is started feeling better. It's actually even in the theater. So the diagnosis and classification of diabetic foot infection must be diagnosed clinically based on presence of local and systemic signs and symptoms of inflammation. A minor problem, even a superficial scratch, can lead to cellulitis, which can lead to a life-threatening limb condition or a life-threatening, which can lose a limb-threatening condition or a life-threatening condition. We need to assess the severity of any diabetic foot infection accordingly. Diabetic foot infection clinicians should evaluate diabetic patients when they present with foot ulcers, and the patient has to be looked as a whole patient, not only the hole in the patient. It is always seen that we are more concentrating on the hole on the patient and we forget the whole patient. So when the treatment is done, it has to be looked at the full patient, the mental status, the metabolic control, which is very important, the fluid status, what are the risk factors, why this patient got this, presence of peripheral neuropathy or an arterial disease, and obviously the infected foot ulcers has to be taken care. When to suspect diabetic foot infection and how to classify it, the classification system for defining the presence and the severity of infections in patients with diabetes. If we talk that these are clinical criteria, grade and severity. If you say that there's no systemic or local symptoms and signs of infection, this is grade 1, which is not infected. If an infection involves only the skin or subcutaneous tissue, that is a superficial ulcer, then this is grade 2, and we call that as a mild infection. And with this, you need two of the following below signs. That's local warm color, redness, erythema should be above 0.5 to 2 centimeters around the ulcer, or local tenderness or pain, local swelling or induration, and purulent discharge. So you have an ulcer involving superficial skin or subcutaneous tissue with at least two of these will diagnose as a mild infected ulcer. Obviously, we have to exclude other causes of inflammation must be excluded, that is gout, trauma, or acute Charcot foot. When you come to a grade 3 or a moderate infection, these are the infections with no systemic manifestations, involve the deeper structures, but it has not yet reached to the bone or joint. redness more than 2 centimeters from the wound margin, and one of the above findings which we already mentioned, this one of this. And deeper structures involves, that is structures beneath the skin and subcutaneous, the soft tissues and other, but the bone joints are not involved here. If they are involved, then this is called osteomyelitis, that is 3-0. So if deeper structures are involved, then the grade becomes 3-0. No systemic inflammatory response, that means SIRS is below or less than that. I'll show you on other slide. Any direction of the rim of the wound, the presence of significant foot ischemia would cause diagnosis and treatment of infections very difficult. Any foot infections with systemic inflammatory response as manifested with one or more than two of the following things, then this is called grade 4, and this is severe infections. But here the bone is still not involved, so you can have a severe infection, systemic infections, but it's in grade 4, but there's no involvement of the bone. So the temperature could be more than 38 degree or less than 36 degree, pulse rates high, respiratory rate high, partial carbon dioxide rate 32, and white cell count, it could be more, or in diabetes, you can see in severe infection could be less than 4,000, and immature leukocytosis. If infections involves the bone, that's osteomyelitis, then it becomes 4-0, that is 4 osteomyelitis, is demonstrated in an absence of, if osteomyelitis is demonstrated in an absence of less than 2 of signs and symptoms of a local systemic inflammation, then this goes back and classified as a foot as a grade 3-0. If it is more than 2, then it becomes grade 4 osteomyelitis. So let's talk about little bit about osteomyelitis. Osteomyelitis is a spectrum of osteoarthritis, both the management of diabetic foot, both laypersons and the healthcare workers would be very conscious, and they will become very worried when they hear that the bone is involved, as usually the prospects for successful treatment are very low. Osteomyelitis is one of the end stage to the path of amputation, but I insist it's not an indication of an amputation. Common problems which we see overall, if you take an infected diabetic foot ulcers, you find 20% of them have already got osteomyelitis. And if you take only those severely infected diabetic foot infection, you see them more than 60% of them have already involved the bone. Usually the overlying ulcers may not be seen as an infected, and it can lead us wrongly. Morbidity associated with there is poor wound healing, recurrent infection of the same wound, prolonged duration of hospitalization and treatment, and increased risk of, in this patient, the risk of lower limb amputation becomes increased by 23 times. Microbiology and pathophysiology, usually we say that the diabetic foot ulcer is a bag of worms, so it's usually polymicrobials, and they usually comes from a soft tissue. Soft tissue is the one when initially starts getting infected, and then it goes to the cortical bone, then it enters inside into intramedullary spread of infection. The bone starts getting dead because of infection. There is also a sinus tract formation, and at the same time, inovicurum, that is new bone, start forming up. The infection and inflammatory also starts killing this sequestrum, killing this new bone, and the sequestrum starts from, that's a dead bone, and gets detached. So this is the process of, in summary, what happened in osteomyelitis. Diagnosis, the current method, history and examination of the ulcers of diabetic foot osteomyelitis. Clinically, these ulcers have got a very long duration of the wound, and they would say that they are being recurrent infected. And there will be also a remission. Sometimes they get better, and then after a couple of months, they burst it out. Maybe they are obscure and not seen with us, maybe associated with cellulitis or a soft tissue involvement, like you can see here, that this is a very small wound we can see, but it was actually an osteomyelitis. And they're usually associated with chronic penetrating ulcers. If you look at the examination, it more than 3 millimeter deep, and large would be 2 centimeter square ulcers, mostly seen on bony prominence, visible bones and joints. And clinically, you can see that they are called, they are named as a sausage toe, which is clinically gives you a diagnosis, just on the spot diagnosis that osteomyelitis is there. Diagnosis, the current method, probe to bone test is most useful, and bedside test useful is done. And if it is interpreted correctly, it is the most convenient and cost effective. For infected wound, perform a probe to bone test. Patient at low risk for diabetes usually have a negative test if it is done, and you can rule out osteomyelitis. A positive test is highly diagnostic, and actually you can feel the grading noise if you touch the bone, and this is how we do it. Blood test for osteomyelitis, WBC, white blood cell count would be usually more, and ESR would be high, C-reactive proteins and procalcitonin, all of them would be measured, would be high. Diagnostic for X-ray, plain X-ray, which is still used, but plain X-ray is limited in sensitivity in early stage. But you can see this patient had a pathological fracture, and they were just cleaning superficially. And this is an obscure wound. Here, clinically, you cannot see initially. MRI is still a variable tool for diagnosis of osteomyelitis, presence of anatomy of the soft tissue, and sensitivity is more than 90%. And there are many new radionuclide scans, WC, SPECT, FACT, and all these are still quite promising available. Biopsy is still the gold standard and is been recommended in the international working group. Culture and histology is a standard. Evidence supports that evaluating a bone specimen for infection, this is the best way to do for microbiology, culture, and histopathology. The situation where we don't have all these gadgets, then the following criteria are used. It is likely when 3 are positive, definitely diabetic foot osteomyelitis, which can be diagnosed. So cellulitis, soft tissue involvement, probing to the bone, and radiology. All these which I have highlighted are present everywhere at the district, even at the primary centers, and in anywhere in the world. So if you have an added positive bacteriology culture, scan, or histology diagnosis, it's better. So any 3 of them, following criteria is likely when 3 of them are positive, you can diagnose easily osteomyelitis. Conclusion of diabetic osteomyelitis, probe to bone test is useful, done and interrupted if interpreted correctly. ESR is probably the best serology test. If advanced tests are available, then MRI is best. Never imagine like SPECT, PECT are promising. And bone biopsy is the best, still the gold standard for culture and histology. People who need hospitalization, potential indication is, and this is international consensus, it might not be useful for us because we do see people worse than this and treat at home, treat as an outpatient. So wound, if it is a penetrated to subcutaneous tissue, fascia, tendon or muscles joint, cellulitis of more than 2 centimeters, or local signs like severe inflammation, induration, discoloration, necrosis, or gangrene. These are the indication to admit the patient. General indications are acute presentation, systemic signs, fever, chills, laboratories tests, which I've already mentioned, leukocytes, high C-reactive proteins, or a complicated features if available, if associated with this sport. Current treatment progressing while you are doing a treatment, but if the progress is not properly, then we need to be admitted. Management of diabetic foot infection, it is interdisciplinary approach, and metabolic control is very important. Tight metabolic control, fluid and nutrition, relief of the pressures, adequate blood supply. We have to start at least empirical antibiotics and usually a broad spectrum antibiotics. If you have a suspicious osteomyelitis, the treatment can go up to 6 to 12 weeks. Meticulous wound, keep it simple, moist dressing heals faster than others. And all these things are essential and have to go hand to hand together. My take-home message, how to prevent problems. Food examination should be performed in patients with diabetes at least once a year and more frequently to those who have a high risk of food ulceration. And I've already mentioned who are the high risk food ulcerations. Identification of patients at risk of ulceration is the most important aspect of amputation of prevention. So we need to identify them in our clinic. Education should be an integral part of prevention, should be simple and repetitive to both healthcare workers and to the patient's relatives. Efforts are still required to increase the awareness of diabetes and its complications among the healthcare workers and patients. Early detections and treatment of diabetes will improve the course of disease, reduce morbidity, amputations, and mortality. I will leave you with this last slide, what Mahatma Gandhi said, live as if you were to die tomorrow, but learn as if you are going to live forever. And our African hero Nelson Mandela said, education is the most powerful weapon which you can use to change the world. And he showed he showed it how he changed the world. And I would say that education is the only powerful tool we have it in a developing world, which is free of charge for the patient and if effectively implemented. Thank you very much.
Thank you,